Well, thank you for joining this breakout session. We're going to be talking about leveraging WISHIN for enhanced EMS coordination and outcomes. We have, including myself, we have 3 other panelists here. I will let them introduce themselves. So let me talk a little bit more about our logistics. This session is going to last approximately 45 minutes. I would love, as well as engagement with the panel, I would love to have the audience engagement as well. So there'll be a lot of time for questions. I'll be asking some questions of this group too, because I do want this to be interactive. And some things I wanted to just talk about first before we start going with the panel and asking questions of the panel is what WISHIN is currently doing with EMS. So we have worked with Image Trend on a pilot. We have one organization, the Milwaukee Fire Department, that is using through Image Trend, is submitting their run sheets to WISHIN Pulse to make available to healthcare organizations. So it's been a long-running pilot. There have been some benefits and some challenges, and we'll talk through some of that. And after we overcome some of the challenges and the things we've learned, we want to integrate with more EMS organizations that are using Image Trend. And then, of course, look at other systems that EMS organizations are using to be able to get their data in our system as well. I think that data is very valuable at the point of care when you have been transporting, when a patient has been transported to an emergency room or in some other type of transition of care. We are also in the process of testing a deeper integration with Image Trend. And I'll talk a little bit about that later after we're done with some of the panel discussion. We also make our WISHIN Pulse system available to EMS organizations, and they can use our system for aftercare, like billing and finalizing what they're doing with the patient use cases. They can use it for when they're out in the community doing community care. They can use it for, when they're on their way to a run. So our health information exchange is available to EMS organizations. And if you are a member of an EMS organization and aren't part of WISHIN, give us a call. We'll be happy to set you up. So with that, I would like to have each of the speakers on our panel introduce themselves. Just a little bit about who you are, your organization, and any interesting details about yourself before we start the actual discussion.
Hi, my name is Christine Pauley, and I have a voice that projects, so I apologize right now. So I work with Rhine Brothers Ambulance in Madison, Wisconsin. We serviced a portion of the lower part of Wisconsin. I've been there for 13 years. I've been in healthcare for 23, and actually my whole life I've been in customer service. So I would be 68 this year, so that's a long time. I've worked with WISHIN since WISHIN took over for ambulances. We were one of the first companies that spoke with Laura about it, and we use it daily. It's made a big change in our day-to-day trying to find stuff, saving us time, and I can't wait to hear more about the Image Trend part since we use Image Trend. So.
Hello, I'm Erik Rhine. I'm the Revenue Cycle Coordinator for Bell Ambulance. I've been with Bell since 2015. Basically, after I graduated college, I went to LSU, and the LSU Tigers here. No? Yeah, kind of far. But moved back, started with Bell. We, like Christine, we use WISHIN pretty much every day. It's helped our organization grow. We're also, this will be a good segue. We also are integrated with the 911 system in Milwaukee. And then
So my name is Joshua Parish. I am a assistant chief with the Milwaukee Fire Department. That's me in the upper right hand corner, just different outfit. I opted for my wife said this is okay to wear, so I got permission for this today. I've been with the Milwaukee Fire Department for 25 years. I've done a little less than that now, less than half of my career in operations. For either from the Milwaukee region at all, or do I have to? Just one person? Two people? Three people? But illustrating from Milwaukee. All right, for the benefit of everybody else, Milwaukee Fire is just under 800 staff people. 750 or so are sworn members from the rank of firefighter up through, really my rank, but we don't, go out anymore. About 200 of those individuals are advanced life support providers. We have them on all of our apparatus. We are a billing agency. We have 29 engine companies, 5 ladder companies, 2 heavy rescues, technical rescue, tactical EMS, so like people going with the SWAT team, dive, hazmat, what I forget. Yeah, everything you need to be got. And then we have 12 advanced life support transporting apparatus that service all of our regional hospitals, and then our wound trauma center, and then our specialty pediatric care center. And we also have a community paramedicine program. So for those of you that are in EMS agencies, we actually normally pilot all the licensure levels that DHS puts out before they put them out. So we've done that for both mobile integrated health and also for tactical EMS. So as far as WISHIN usage, kind of like Laura alluded to, we've been playing with the integration stuff for a while now. We use it a lot more in our community paramedicine programming, and also in a lot of our CQ and CI stuff that comes up. Just like the sheer volume that we run and the speed that we run some things like en route to patient, our average response time is like 3.5 minutes. So it doesn't really work out great for us for en route, but a lot of our aftercare stuff is a lot more what we're doing. And then we actually got engaged when we were doing building out all of our post opioid response stuff. WISHIN was integral in actually doing a patient attribution study for us. And yeah, that's how we got to where we are. And I like Marvel movies and runs on the beach.
We can have a discussion about Marvel movies later, because I love Marvel movies.
Great. Because if you're like, I'm a DC fan, we're going to have beef.
Same here. Agreed. Thank you so much for everybody for introducing yourselves. I have some questions I'm going to be asking the panel, and also I would like to see some group engagements. Any questions that you have in response to what they say, I would love to hear them. So here's some of the main questions I have for our panelists. They've already talked a little bit about how much they've used WISHIN Pulse. And I'm curious as to what your processes were before you were using WISHIN, and some efficiencies you've gained in your current use, and how this has helped you improve any kind of patient outcomes.
So before we joined up with WISHIN, we had nowhere to go to get insurance information other than to go to each insurance company and try and look everything up. We would call the hospitals, the clinics, the nursing homes. We spent a lot of time on the phone that took away from our billing that I had the people doing. And then trying to find someone at the hospitals that could help you. That was always a challenge. How many people here are actually from hospitals? Just a couple? And the rest of you from insurance, or not of you? So one of our hardest ones then is Blue Cross Blue Shield. And if you don't have a member ID, you can't look them up. So being that we've gone to WISHIN, we don't spend any time on the phones anymore at all to look up insurance information. And another thing is the insurance companies, or when you get the face sheets from the different facilities or the clinics, a lot of time they haven't even had time to input their new addresses, insurances, phone numbers. So we're able to pull all that information from WISHIN so that we can make phone calls to the patients, in our recovery process. And, we are able to bill immediately versus having to sit and wait until we get a face sheet from a facility. And I'm sure Erik probably can attest to that too.
Yeah, before WISHIN, I would call those the dark ages. Lots of paper, like Christine said, lots of faxing. for updated face sheets, demographics, things like that. So that's not only taxing on our agency, that's also taxing on the hospitals or the clinics. And being in emergency medicine, we don't always have a complete picture when we arrive on scene. You know, there's a lot of people that can't give us their name or their date of birth. What WISHIN has done, instead of calling the hospital, hey, we have this John Doe, I mean, how many John Does were there that day, we can now use the MRN from the initial registration to find out who that was. In EMS, we help you, but we can't help people if there's no funding. Nobody does anything for free, unfortunately. But yeah, before WISHIN, our process, again, faxing hospitals, calling, it is essentially eliminated that. So.
All right, so I'll talk about the non-hospital stuff then, because I think they both covered all those items. In full disclosure, we actually use a third-party billing service. Once again, just from the sheer volume of, I would need like a full-time billing staff for that, and it's just not realistic. I think we probably, not including you guys, probably like 85,000 individual encounters a year. So that's just not feasible for us. For us, I guess I'll do the patient attribution thing. Have you guys ever spoke about that project from a few years ago?
No, we haven't.
All right, cool. Then I'll talk about that one then. So let's rewind a few years back, just pre-pandemic. Obviously, we have a lot of different types of callers, and we have several high utilizers for whatever the reason is. So we have a separate division of the fire department that does mobile integrated health that we basically carbon copied from the group at Fort Wayne and then put our own local spin on it. So then when the opioid epidemic kind of became a thing, one of the questions that we were asking was, okay, we have very good connections to our hospitals and healthcare systems. Probably not so much the calling level, but we know people who can call, figure out this thing. So we were actually wondering if there was a way for us to intervene to identify common prescribers in our local systems. But there was no great way for us to get longitudinal patient information from EMS encounters because that's just not what the record is built for. That's probably when we first reached out to WISHIN and said, hey, we have this massive database of hundreds of thousands of patients who are our patients. And here are all the permissible uses from CMS for HIPAA information, so on and so forth. We're looking to figure out if there's a way to identify if there are common prescribers or PCPs amongst these patients. And then we extracted all the treatment codes. What we used to do, is anybody familiar with the recommended 911 usage for non-fatal opioid interventions at all? So that's actually a Milwaukee Fire Department product. We actually made that. Now the Biden administration says what you should do. So we actually shifted from calls for service for opioid or for overdose in general, which is a really, really broad category. It's Milwaukee, so you get everybody's intoxicated, should be in that bucket, because that's an overdose too. To the clinical administration of naloxone, which actually has a procedure code. Then we can extract those codes, extract those incident numbers, extract those patient demographics, and then we ask WISHIN, hey, can you then extract those providers? So basically, we worked backwards to see if there were prescribers who are actually popping out more often than not in our patient volume, because we realized a while ago that there's no strong correlation between calls for overdose and actual people that we're treating for opioid overdose. It's less than half for us. What we discovered was a lot of things along the way. One, I learned how to speak HL7, which is a different language. Two, fun fact, there is no code for primary provider. It's just whoever writes prescription. I learned that you guys have access to the prescription database, and we actually discovered a lot more utilizers in our system than even we knew. And we actually discovered that we actually had drug seekers in our systems and people who we had treated multiple times with opioids who would never have otherwise popped up in my queue. But because we were using this patient attribution methodology, it's what then fueled our program, really kind of getting that jump start to being what it is today. So one of the interesting tools that we've kind of utilized WISHIN for is actually as a research partner, because some things, as we process them in bulk, the normal epidemiological research ways to do some of this work would have taken us years. In reality, we cut a check and said, push us over a CSV file, and probably took a couple months, but the file did come. So it's kind of a cool thing.
Thank you so much. So we've talked about the great ways that they've been. Do you have a question?
Yeah, I'm gonna ask the question, I'll make it interactive. So, large systems. So everybody can hear back. Sorry about that. No, that's okay. Are rural EMS systems using this in Wisconsin? Because it sounds great, and then I'm thinking you were talking about the time spent at the hospitals calling in, but vice versa, that takes a lot of time from the hospital staff, especially in small rural hospitals where there's not a lot of people, so.
We have visited and talked to a lot of smaller EMS organizations. We haven't had any takers yet, but we're hoping to expand it, especially as we integrate with the systems that they use. We're hoping that we have a lot more people, a lot more organizations join up, because it does help in that transition, that handoff between the EMS organizations and where they're transporting. So we would love to have more local EMS organizations and smaller EMS organizations join us. We do have a lot in the Milwaukee region, but they're all larger systems again. They're all larger organizations. So we would love to branch out to some of the more rural ones as well. So if anybody knows anybody in some of the local ones and they want to hook us up, we'd be happy to.
So the first question that they're going to ask is, what's the cost to them? Because these small rural EMS services are largely volunteer. They
Right.
maybe have a paid staff person or two at the most, and their budget simply wouldn't allow an expenditure like this.
That makes a lot of sense. One of the things about WISHIN is how we structure our costs is based upon the size of the organization. We don't want to be exclusive to large systems. We want to make sure that our systems are affordable to everybody. So I can't say exactly what costs are for smaller organizations. Steve and Greg, that you've been introduced to in the main session, are the ones who deal with all the money and the contracts. But I can say that it is structured so that we can make it affordable for anyone who wants to join. There's also possibilities of maybe banding together, so there's thoughts about that as well. I wouldn't let cost be a factor, because we want to work with organizations to get everybody connected for the benefit of the entire network and the patients.
And I will say, full disclosure, the Milwaukee contract is not a Milwaukee Fire Department contract. So kind of Laura's point, we worked with our health department, who also has a WISHIN account, and most of your health departments probably do disease surveillance or something like that. So part of our cost is borne by the health department. Your bill will not be my bill, because my use is not your use, so don't worry about that. But yeah, to be clear, if you can be creative about structuring your contracts, who has a jail in their area at all? You don't have to be ashamed. We have several. No, that's fair. And we do a bunch of businesses with the jails. It's a big city, so it's just a real thing, right? We got our county jail a WISHIN account. It dropped their call volume by 90%. Because the nurses at the jail didn't have access to the prisoners' medical records, so they would just call 911. I'm like, this has got to stop, right? But because they have advanced practice nurse, they have a pharmacy on site. They have the hydrochlorothiazide there. They just don't know what the dose is, and they can't get that information without kicking that person out from their system. I'm like, let's just stop. So we introduced them their WISHIN. They got an account. They can now look up every inmate, get their full medical record, and then treat them on site without having. It went from 1,000 calls a year to we maybe do a few a month. What do you guys at now?
Yeah, I don't see. You're right. We used to see a lot more.
So one building, a 90+% reduction in demand from basically just having them partner on a contract. Sorry.
Any other questions before we move on to the next one for the panel? Okay. So we've talked about the benefits. We know, especially with our EMS use cases and our EMS using, it is it's new. We're still learning. And so I'd like to hear from the panel, and I'll also talk about some of the challenges as well. But the challenges you still face that you're hoping WISHIN can help you with, kind of a wish list for WISHIN. I'm also going to talk about some of the challenges we found just in our pilot and how we're going to be working to overcome those as well. But
We've already taken care of two of my wish lists, which is Fort Hospital and Unity Point Meritor. So they are coming on board. So that was one of our problems. So we service in Madison, Meritor Hospital. We're contracted with them. We can't pull up any of their records because they were not on WISHIN. Same with Fort Hospital, who we also have a contract and service. And it makes it very hard for us to, we'll get a denial from Medicare saying they're inpatient. Well, where were they inpatient at? And we can't find it because they're not in there. So, that's a big thing. If there are other hospitals that aren't on there, that aren't in my service area, I mean, we're a private ambulance versus the public over there. It's something to look at to help the patients, because otherwise they end up with bills.
I will say the thing I found intriguing about the WISHIN 2.0 sneak peek was that you can look people up by their address or phone number. That might come in handy. But yeah, as far as, is anybody here from an insurance company? Great. The thing that I think at this point, with how advanced it has become, I think would be very helpful would be benefit information, deductibles, co-insurance amounts, coverage, putting those details on the site. Another thing I think that would be beneficial for WISHIN to maybe look into would be more integration. I know we'll probably touch more on that in a few minutes, how Milwaukee Fire piloted the program. Bell is very close with Milwaukee Fire. We're private, but we are integrated with the 911 system. So usually when they do something, we will likely follow suit. So
for us, and I'm sorry, yes.
I have a question about when you said the calls you were looking forward to looking up by address. Today, how many patients, when you go to a call, would you say, percentage-wise, you don't see in the system, or you can't look up because you can't find them, or you don't know who they are? Do you have just a round percentage, or?
I will say with WISHIN, it has made it a lot easier, especially with the use of the MRN numbers. I think the big thing is that you need a starting point. Mm-hmm. If you don't have a name, but you do have that MRN number from the hospital, and once they update it, we can update it. So it might be listed as a John Doe initially, but later come back as Jack Smith. So it's important to have that starting point. In EMS, we just sometimes don't.
Yeah, that was going to be my next question to you, Laura. Does the EMS entities have their own MRNs?
Ooh, let me do that one, because I was going to say that. We don't. That's one of the challenges.
Okay.
So I guess to kind of piggyback, unless it's a John Doe, I don't know that I've ever tried to look up for something I couldn't find. So
have you ever looked up somebody that you found more than one?
Oh, absolutely.
Okay.
Because we have multiple competing systems
Yep.
in the city. And then even for like your early 20 population, you may get a children's record and then an adult record. Mm-hmm. A lot of people have records across every system. So yes, you're going to get multiple hits on patients kind of no matter what, because the reality is like the systems don't work well together. like like UW Health doesn't talk to Freighter, doesn't talk to Advocate Aurora, like so that that's kind of just the reality of that. So yeah, you're going to get multiple hits no matter what, which I'll be honest can be a benefit because some systems specialize. If you're doing like so a lot of our stuff is advanced case management that we're our use case. Rogers is a separate thing, and that wouldn't appear in somebody's Freighter record.
Okay.
If I need to track down a case manager, it's going to be, in a BH note that is not going to be in, it probably won't even be in their primary healthcare provider service network. So part of that is also beneficial. We don't have MRNs, and I know that I'll kind of share kind of how we came to the patient lookup stuff and kind of what well and what didn't. And once again, this is like a major metro issue. Some of your sites, you may not have this. We tried a different service to do automatic lookups. And then what it was doing is, do you all know what sensitivity and specificity are? Some people yes, some people no. The people who don't know aren't going to raise their hands. All right, so I'll explain it. So sensitivity is the, your odds of right about being right and then right about being wrong. So when you're doing lookups in some other systems, if you get too many positive matches, it will return a null, which is a problem in a big city because I do have a lot of John Johnsons. I probably have 200 2,000 John. So like that's an issue for me to not just show me everything and then allow me to go, nope. I may treat multiple people in the same day with the same name. Like that's not uncommon at all. So I don't need the ocean, but I need to be able to pull out a gallon of water and then sift through the sand to find people. So Pulse allowed for me to have that ability. And the reality is like for us, that's not something I would ever ask a provider to do on the way to a call. That's just not realistic. And with our hospital transfer times, it's also not going to happen between home and hospital. Something that we do way on the back end when I have to disaggregate those situations, and they do occur a lot. What we were looking for was a lot more of that dynamic patient lookup, which we had years ago, three sets of CMS rules ago. You can put in somebody's social, it banged on the social, and then it kicked out. And our providers got to the point, good, bad, or indifferent. The first question was, what's your social? Right. Because the reality was from that, I got everything else I needed. And it took, 6 questions out of the initial patient encounter. It's no longer an option. So that's kind of what the experiment was looking to do, was see, okay, can we build that back knowing that we actually do have richer medical data sets that aren't social security number driven, but that could also give us additional information like past medical history from a care provider's perspective. We were hoping to be able to get pharmacy information. So like we had like our wish list of stuff that we were looking for. The reality is I think we ran into is like HL7 and NIMSIS do not play together at all. Anybody here from the feds or from DOT? See, they should be in the room. But I mean, I think that was one of the biggest pinch points is that, part of creating an MRN is being able to narrow down that patient enough to be able to have a unique identifier and then use it over and over again. We have multiple unique patients, or we have multiple repeat patients, but we were never able to get to the point where we're able to say, like, for our system, here's a reliable methodology to build an MRN, because our patient encounters, once again, major metro are super short. If you're from a rural area, you have like a 45-minute time in each direction, maybe a great fit. Like it's one of the defaults of our system is that it is rinse and repeat down to 20, 30, 40 minutes tops sometimes. We don't do encounters over an hour, ever. So yeah, that was one of our, and continues to be one of our big pain points, is just that fidelity of demographic data. Because my providers just are not great at that. I mean, at 3 o'clock in the morning, like, you may double type a L, you may miss a hyphen. Even if you do the text recognition, like we had to turn that off because it wasn't good enough for the O's and the zeros not to conflux. And the reality is, like, when you're looking at it on the screen, you probably can't even tell the difference between an I and an L. And that was just killing all the demographic fidelity in our system. And once again, and we get a ton of John Does too. So we did, or I'll be honest, we're still working on figuring out what that answer is. I don't have a great answer for you. And on the back end, like I said, HL7 and NIMSIS do not play nice at all. So we worked with some other providers who could we build our own translation? Feds have been promising one for more than a decade, doesn't exist. And then we ended up at the same spot of the fields just don't always match up in a reliable, usable way. From a billing standpoint, you're doing it differently. From a auto dump into a EHR, it's a very, very different thing. So it continues to be a pain point. We do actually the reconciling John Doe's works out more decent now, because like I said, as long as we get a starting point, I can drill it down. Interestingly enough, that was my phone call right before I came here. Is we had a case and person was resuscitated. They wanted to congratulate the crew. It's like, great, I don't know. You were John Doe when you went in. So now I have to sort through the John Does to find the person that we resuscitated. And now I know who he is. Now he's going to get a bill. Because he was a John Doe before. So awesome for him. But I mean, so like, that's kind of where that balance lies. And it's one of the benefits of being a smaller agency is that, like, you'll have a lot more of the ability to kind of comb through those things, and you won't have some of the issues that I have, or we won't need some of the functionality that I need because of the sheer volume of it. So there's definitely some benefits to being smaller and being able to do some more intimate one-on-one things that, like I said, for me, I'm always looking for automation.
We might be able
So-
to talk. I do identity management, so we might be able to.
Best friends.
Yeah, one of the things that I was going to say is with our WISHIN 2.0, we're moving from a passive patient matching and demographic matching scenario to a very active patient matching scenario. And Kim, who's been asking the questions, is going to be helping WISHIN with that. So she's going to be working with us on that. One of the things we definitely want to do, especially with like the EMS data that we're getting, is to improve the patient matching. Definitely improve it. Other ways we're going to work to improve the patient matching is we're currently testing a process that the organization like Milwaukee Fire can enter in limited patient demographics into their system. Their system queries our system to pull back the healthcare information and does the matching as well. And then you can implement the rest of that patient information into your records, so that way when the run sheets come to WISHIN, it all matches up with the hospital beautifully. So that is something that we're testing right now as well to improve that patient matching. And then the active matching management process that we're putting in place with 2.0 is going to take it to the next level. And it's kind of a secret. It's for EMS people. For EMS organizations specifically in WISHIN 2.0, so I didn't mention in the general session, we are also offering a search capability that you can search by admission, date and time, and facility. So for your John Does, if you don't have a place to start, you can pick the facility where that patient was dropped off, the date, and the time frame that happened, and you'll be able to see the admissions and find your John Doe.
I mean, that's a pretty good starting point.
Yeah, so we wanted to help with the John Does and Jane Does to help you get an accurate patient match and find your patients. So that is another thing that's going to be in 2.0. It's not available for every single user. Most users won't really need to use it because they'll have an MRN or they'll have a name. They'll have that information. But we're going to make that starting point available for EMS so that they have something else. Any other discussion points we want to cover today or with our panel, or any questions you have for them? Well, I also would like to ask the group, everyone who's attending, what challenges do you encounter in day-to-day coordination or transitions of care with EMS organizations? And what are some ways that, WISHIN could probably help with those, overcoming those challenges, help with better integration and coordination with EMS? Any challenges from the audience? Wish lists? Nothing?
Can I ask a question to the insurance company people in the room?
I saw a few of them raise their hands.
Oh, wait, he has
I was just curious to hear more on the what you talked about, the attribution list. I work for Anthem Blue Cross, quality director for the Medicaid plan, and we've got different work groups with especially centered around behavioral health and individuals who are sort of frequent flyers, often request help kind of regularly. And we're actually trying to partner with Milwaukee County. One of our managers reached out, and we're trying to sort of look at how this can work within our budget and pricing, and work with you to, I guess, outreach to those members to get them more involved in case management, that kind of thing.
Don't we already have a contract? I think we already have a contract with Blue Cross Blue Shield for that. It may have been expired, but I thought didn't we at one time do that for you guys? Or is it different?
That could be
Subgroup.
maybe that might be commercial or Medicare.
It could, and it also could have been internal medicine. It wasn't BH focused. We found a lot of BH overlap. All right, so I'll answer your question in two parts. So the patient attribution study was something that we did a few years ago, and like I said, it really, there were a few, I wouldn't even call it hiccups, like learning tools. Like there are things that we think should exist that just didn't exist because there's no coding for it. And it ended up being, and Laura, correct if I'm wrong, a mashup of a few of the different data sets, and I think we ended on the prescriber data sets, on the prescriber information for the patient that we had, because we were actually specifically looking for prescribers, and it wasn't specific to who that prescriber was in that patient's history. So the prescriber information doesn't say if that prescriber is a specialist, if they're a PCP, if they're a orthopedic surgeon, if they're a neurologist, if they're an NP. It was just who the prescriber is. So it was helpful. It was a starting spot for us. But yeah, that's kind of how that project worked. We pushed up, first name, last name, social, and DOB. And then whatever we got back, we were happy with. I had a big enough in where that was enough. As far as longitudinal follow-up, that's definitely something that we do. I have an entire division that does that. It's they have their own contracting and so on and so forth. So they could work you a price if a lot of your enrollees are Milwaukee residents. If they're broader across the county, then you can go with the county either or. And yeah, like I said, a lot of that then comes to us finding them. One of our benefits, we can just, it's a separate division, so they're not on fire trucks. They have 4, not escorts, escapes now or whatever. But yeah, they'll just show up at the person's house, and we're good at finding people because we keep all our 911 data. So I just basically look for the person's last encounter in our queue, wherever that was. It may not have been home, which is one of our benefits, is that, look up by address. By the way, I have a blacklist of address for you if you want them. There are places where you should never send a bill to. All of our bridges have addresses. Fun fact. So yeah, I think we have thousands of blacklist address in the city. Never send a bill to Miller Park, to the Fiserv, where we get a lot of patient encounters. So because people tailgate and get drunk. So yeah, we and I now know what timely filing is, because after our billing company sends 7 bills to AmFam Field and they don't come back. So yeah, there is a blacklist of addresses. Fun fact. But yeah, we use it a lot for that because, like I said, it's helpful for us to be able to link things from different systems. And then we also have a city ordinance in Milwaukee that allows for us to coordinate care planning and convene users for high utilizers. So we actually had it written in the ordinance because it became such an issue that if we have somebody that exceeds a 90% threshold of our EMS volume, they're auto-enrolled in our program. And then it allows us to go every hospital system, our medical director, the insurance company, your medical director, whoever it is, they can all coordinate and have an open private conversation, isn't public record, about that individual's longitudinal service. Getting somebody to do the thing is a different thing, but they can have that discussion. So yeah, it's definitely something that it's a tool that we use because we can also dig into that record and go, one of the most useful things ever I had, probably, we're recording this, aren't we? I won't tell you the context of the story, but very challenging patient, very disturbing behaviors, especially the EMS providers. This patient went from doing this with us to doing this almost exclusively with Bell. To the point where Bell got to the point where this is just ridiculous. We're not going to do this anymore. Police really couldn't get involved. I dug through the record. I found multiple social workers' information. I called the last one. He was like, "Oh yeah, let's talk about this," because I'm very familiar with this case. And the guy was like, "Here's just what you do." I haven't seen this person since. So I was able to find the one case manager's phone number and their one note that said exactly what to do, and they were open to having a conversation because we had all the framework set up. So that's some of the usage of, like, when you're doing stuff in the community paramedic space, that if you have access to those care notes, they are long form narrative format, but there's a gold mine of information there because BH encounters are a very, very different thing than biological health encounters. Oh, my question for the insurance companies, actually. For the few that raised your hand, would be super helpful, I think probably for me and maybe for you all too, is like, for you all to share, and granted, this may kind of be taboo, but like, for the things that we get rejected for the most, like, whether there are things in our EHR and our health record, like to know exactly what you want for those, because like that black box is disturbingly perturbsome because we only find out months later what that is. So, and like I said, HL7 and NIMSIS don't talk to each other. So that's always going to be part of our billing challenge, is that our coding language is totally separate than yours. And then we have to translate all those things to be able to put, so, I mean, even for the vendors in the room to have like validation code that either did or didn't hit when we met your rules would be amazing for us, because that's probably the next level point of frustration.
Anybody want to?
They're not going to volunteer to spend
Yeah.
Some of the other things that WISHIN's going to be doing to help out healthcare providers and EMS is we have a data governance committee now. It was formed as part of our DAV process, which you heard about in the main room. But this data governance committee is a group of healthcare professionals and payer organizations. I don't think we have EMS representation, but we should, and we'll remedy that. But it's a group that is now starting to meet to talk about what kind of data is in WISHIN Pulse, what kind of information is available, what are some standards we should adopt, what is more information that would help the healthcare community as a whole, like if hospitals could send like how the patient arrived by ambulance or by self, or being driven by a cab or something like that, as opposed to not having that information. You were talking about more benefit information available in the system as well. Those are things that the Data Governance Committee is looking at right now, prioritizing what are the needs to improve the quality, quantity, and completeness of our data, and make some recommendations to participating organizations to truly make this a very connected, interactive, and beneficial network to all the participants and eventually the patients. So through that data governance committee, we're hoping to be able to work with our participating organizations on, improving the completeness of the data to help all kinds of different organizations that are members of WISHIN. And we should talk sometime about NIMSIS, because I do have an organization that we work with has been translating NIMSIS. He did a project. We should talk about that. But we are running close to time. So I do want to give you guys a break before lunch. But are there any other questions, discussion points, anything with the panel? This has been a really good discussion. I'm glad everybody was able to join. But any last questions or discussion points that you have? Well, this has been recorded. Our contact information is all over in these presentations. If there's any questions you have, anything you want to reach out for, want to join WISHIN, be part of this network, feel free to contact WISHIN or contact me directly. And I want to thank you all for your time, and especially to our panelists. You guys were great. Thank you for having an open and honest discussion and telling us about your experiences. And lunch will be served back in the main room at 12. So please, take a little break and then enjoy your lunch.